All right, thank you for joining our webinar today. Our theme is Bridging Health and Healthcare. Our topic is implementation and diffusion of the New York City Macroscopic Electronic Health Record Surveillance System. I'm Rick Ingram. I'm an assistant professor at the University of Kentucky. I'll be moderating today. Our presenters are Tina McVeigh. She's the Director of Research for the Division of Family and Child Health at the New York City Department of Health and Mental Hygiene. She was the principal investigator in the project we're talking about today, which relates to the implementation and diffusion of the New York City Macroscope Electronic Health Record Surveillance System. Our other presenter is Liz Lurie, and she was the project director and a study investigator on the New York City Macroscope Chart Review Study in the Division of Epidemiology at the New York City Department of Health and Mental Hygiene. So, Tina and Liz, would you like to start?
Thank you. Good afternoon, everyone. We're delighted to have this opportunity to orient you to the work that we're doing to advance the field of electronic health record-based chronic disease and risk factor surveillance. We've recently concluded a 3-year project to develop and validate the New York City Macroscope Electronic Health Record Surveillance System. A year ago, we were funded by the Public Health Services and Systems Research Program to extend our work by assessing the generalizability of New York City Macroscope surveillance indicator definitions to providers and EHR vendor platforms outside of the New York City Macroscope system. That's important because the New York City Macroscope was designed to operate in the context of New York City Department of Health and Mental Hygiene's unique systems that are unlikely to be found in other settings. The primary goal of our PHSSR project is to assess the generalizability of New York City Macroscope surveillance indicators across EHR platforms to inform electronic health record surveillance system development in other jurisdictions. Today, I will give you a whirlwind tour of the New York City Macroscope validation project. My colleague, Liz Lurie, will then describe the methods of our chart review study and present early findings from our PHSSR project looking at records that did not contribute data to the New York City Macroscope. With EHR uptake exceeding 80% nationally, data that once lived on the shelf are now available for quality improvement, research, and population health surveillance. In New York City, the Primary Care Information Project, known as PCIP, was created in 2005 to accelerate the uptake of prevention-oriented EHRs in traditionally underserved communities and to support the adoption and meaningful use of EHRs throughout the city. At present, PCIP's work focuses on EHR adoption and meaningful use, quality improvement, interoperability, and public health monitoring. The New York City Macroscope falls within the public health monitoring function and draws its data from PCIP's population health system known as the Hub. This is right here. The Hub is a network of practices that use eClinicalWorks EHR software and have signed business associates agreements to share data with the health department. Hub practices are distributed throughout New York City and serve between 6 and 37% of the population in each neighborhood in 2013. Data exchange on the Hub occurs using a distributed model. SQL queries requesting counts of patients who meet specific characteristics are sent to all Hub practices. The practices run the queries and then transmit the count data back to the health department. All computations occur behind the firewall and no personally identifying information is exchanged. To build a table, you need a query for each cell. A total of 48 queries are required to build a 2-level New York City Macroscope indicator stratified by age group, sex, and neighborhood poverty level. This slide shows how we filtered data from the Hub to arrive at the final New York City Macroscope sample. We plan to assess the impact of a similar filtering process with the chart review records. As you can see here, the initial record poll captured data on 1.3 million patients ages 20 to 100 living in New York City who visited one of 660 practices in 2013. So that's the data that came from the general querying. After excluding data from specialists, the sample size was reduced to 766,000 patients. Our final sample includes 716,000 patients after eliminating data from providers who did not meet documentation quality thresholds that are largely aligned with Stage 1 meaningful use criteria. This final sample represents 11.5% of all adults in New York City and 17% of adults ages 20 and older who saw their primary care provider in the past year. The New York City macroscope sample has an age and sex distribution that is similar to that of the New York City population. Women are slightly overrepresented at 57% of the sample, and men under 40 are underrepresented. The New York City Macroscope project was developed to demonstrate whether EHR data could be used to produce valid population-based prevalence estimates in New York City, and to disseminate the information that we learned in doing so to other jurisdictions. We asked two main research questions. To assess the construct validity, we asked, are prevalence estimates produced from EHR data comparable to estimates from well-established surveys? And to assess criterion-related validity, we asked, within individuals, are health status classifications assigned by the EHR algorithm comparable to classifications based on survey data? You will hear more from Liz later this afternoon about our third research question, which is whether EHR surveillance indicators designed for and used by the New York City macroscope are valid when applied to medical records from other EHR systems. To answer our first research question, we compared age-adjusted population-based prevalence estimates from New York City macroscope to estimates from the New York City Health and Nutrition Examination Survey. Survey estimates were restricted to the population that had seen a doctor in the past year, and New York City macroscope data were weighted to the age, sex, and neighborhood poverty distribution of this in-care population. The chart review sample was also drawn from the New York City Haynes in-care population. Our reference survey, New York City Haynes, was modeled on the gold standard NHANES and collected both self-report and objectively measured outcomes. The New York City macroscope indicators were developed to measure the prevalence, treatment, and control of diabetes, hypertension, and high cholesterol, prevalence of obesity, smoking, and depression, and the uptake of influenza vaccination. These domains were chosen because they are associated with a high burden of disease. We expected some measures, such as obesity and hypertension diagnosis, to perform well. Others, such as depression and flu shots, were selected because we expected them to perform poorly. Depression screening rates in primary care practices are low, and flu shots are available at pharmacies and workplaces. Data were pulled for each of the 12 sex by age by neighborhood poverty level strata so that we could weight the data by these factors. We've used a variety of metrics to assess the validity of New York City macroscope surveillance indicators. I will present t-test and Spearman correlation results obtained as part of our population estimate comparison work, and Liz will present sensitivity and specificity data from the chart review work. And now for the results. We compared prevalence estimates from the New York City macroscope to estimates from the in-care New York City Haynes population. Based on our a priori criteria, we found that some indicators were valid while others were not. The New York City macroscope estimate of obesity prevalence was significantly lower than the directly measured New York City Haynes estimate. And so you see a statistically different t-test p-value However, the difference was only about 3, I think, percentage points. And what we found was that our telephone survey measure of obesity is actually lower than the New York City macroscope measure of obesity. So even though by the t-test it's significantly different, we still think obesity is a good measure. And we used other criteria beyond t-tests to look at differences such as prevalence ratios and 2 one-sided t-tests of equivalence. And the obesity findings were mixed. Some were showing differences and some were showing equivalences. Okay, moving on. New York City macroscope estimates of smoking, diabetes diagnosis, hypertension diagnosis, and cholesterol diagnosis are not different from New York City Haines, but estimates of depression prevalence and influenza vaccination uptake are both significantly lower. The correlation coefficients represent the internal consistency of New York City macroscope estimates relative to the New York City Haines estimates across strata defined by age group and sex. With the exception of depression, the indicators are internally consistent, and 4 demonstrate perfect correlation. In summary, New York City macroscope estimates of smoking, obesity, hypertension diagnosis, and diabetes diagnosis are very good or excellent. Results for cholesterol diagnosis are qualified because the age restriction reduced the reference survey sample size and widened the confidence intervals, making it more difficult to detect differences. Cholesterol screening is only recommended to start at age 35 in men and age 45 in women. And so that created some methodological challenges in this work. Another issue with cholesterol is that screening is only recommended every 5 years, and so that has implications in terms of the quality of these data until EHRs have been in place for a bit longer. We hope that detailed results will be published shortly. We have 3 papers in the publication process, one describing the methods we use to build and validate the New York City macroscope. The second documents validation study results for indicators of smoking, obesity, depression, and flu shots. And the third presents results related to diabetes, hypertension, and cholesterol prevalence. Now Liz will tell you more about our chart review study methods and present preliminary findings from our PHSSR generalizability study.
Okay. Do a little shuffle here for a second.
We just have to change seats. Where is it?
Are these p-values and t-tests?
Yes, the p-values are from the t-test.
And let's answer the question in the box. Okay. I am going to dive into the chart review study. The overarching research question that we ask in the chart review study is, are the health status classifications assigned by the EHR algorithms comparable to the classifications made by survey data? The specific question we ask in our PHSSR research project is, are the New York City macroscope surveillance indicator definitions generalizable to EHR data from other sources? More specifically, does generalizability, quantified as sensitivity and specificity, improve when records are restricted to those from either a subset of practices defined as groups of public hospitals versus hospitals and academic medical centers versus single-site, private group, and nonprofit practices versus networks of small groups? Or does that generalizability improve when we restrict to practices that have achieved stage 1 meaningful use? As Tina mentioned, our sample was nested within New York City Haines 2013, and NYC Haines participants were considered eligible for the chart review study if they visited a medical provider within 1 year prior to their Haines interview date, and if they saw a primary care provider, so not a podiatrist or an oncologist, etc., and if they signed a consent form and completed a HIPAA waiver granting us access to their medical records, and also if they saw a provider that uses electronic medical records. So we didn't include anyone whose doctor uses paper records written by hand. So a little bit about data collection. We requested copies of medical records from over 200 providers throughout New York City. We had a team of medical and nursing students work with us over the summer, and they reviewed the medical records and abstracted data from the charts to a secure server. Medical record data was abstracted from the data of the participants' New York City Haynes interview back to January 1st, 2011. And data was abstracted on all of the macroscope indicators, including BMI, blood pressure, lab data, ICD-9 diagnosis codes, medications, etc. And additionally, data was abstracted from structured fields as well as unstructured fields, such as free text, notes, and scanned PDFs. The scanned PDFs are often lab data that aren't incorporated into the EHR. We then compared the individual's medical record data to their responses and objective clinical measures from NYC Haynes. We treated the NYC Haynes data as the gold standard and computed the sensitivity and specificity of each individual. And so now I'm going to go into some of the preliminary results. So this diagram shows the sample for the chart review study, and we started with an overall sample of 1,524 participants in New York City Haynes. And as you can see, a total of 1,135 of them saw a medical provider in the past year, and 692 signed a consent form for the chart review study, but even less completed a HIPAA waiver granting us access to their medical records. And of those that did sign a HIPAA waiver, 20% were excluded because they saw a provider that uses paper records. And other reasons why folks were excluded included they had no visits in our look-back period, we were unable to locate their provider, or it was an excluded type of specialist. And our preliminary data set includes 215 eligible medical records. Since these analyses were done, our sample size has grown a bit, but for this presentation, we're going to stick with these numbers. 48 cases visited a provider that contributes data to the macroscope, and 167 visited a provider that does not contribute to the macroscope, which we refer to as all other records. These 167 cases saw providers that use a wide variety of EHRs and are at a variety of practice types. So here are some of our preliminary results. On the left, we have the 48 cases where the participants saw a macroscope provider, or a provider that contributes to the macroscope system. And on the right are the 167 charts from participants whose providers do not contribute to the macroscope. And we look at a number of different indicators and look at the sensitivity and specificity. And as a reminder, sensitivity is the true positive rate, and specificity is the true negative rate. We present data on obesity, diabetes diagnosis, hypertension diagnosis, smoking, cholesterol, influenza vaccination, and depression. We set a priori criteria for the sensitivity and specificity coefficients. These were 0.90 and above, which were considered excellent and are in blue. 0.80 to 0.89, which were good and would be in green, but there are none of those on this chart. 0.70 to 0.79 we identified as fair and are in yellow. There's only one of, and then below 0.70 are in orange and are considered poor. First indicator on this table is obesity, and as you can see, obesity performs well among the macroscope charts as well as all other records. The obesity indicator demonstrates excellent performance across all EHR systems and can be adapted everywhere. A few rows down, you'll see the cholesterol diagnosis indicator, which is in orange for both macroscope and all other records. And the cholesterol indicator currently performs poorly in both macroscope and non-macroscope records, and we think this indicator, as Tina kind of mentioned, we think this indicator could improve with a longer look-back period because the testing recommendations for cholesterol are every 5 years. Going on to a few of the other indicators, Diabetes diagnosis, hypertension diagnosis, and smoking status all have perfect sensitivity among the macroscope charts, but they perform less well among other providers. The diabetes diagnosis data shows good results across systems, but we think sensitivity may be improved by excluding records that don't meet certain data quality thresholds. And hypertension diagnosis data and smoking indicators perform well in the macroscope environment, but poorly in the general non-macroscope environment. And as somewhat expected, the influenza and depression indicators have high specificity, but poor sensitivity in the macroscope charts as well as all other records. So some of the implications and significance. The New York City macroscope indicator definition of obesity is generalizable across EHRs and may be used by other jurisdictions with minimal local level validation. Some other implications and significance are we are currently exploring if the EHR vendor, practice type, or provider type impacts generalizability. We saw excellent sensitivity and specificity among diabetes, hypertension diagnosis, and smoking among macroscope charts. In the next phase of our project, we are exploring whether applying inclusion and exclusion criteria will improve the sensitivity and specificity of these indicators among non-macroscope records. The inclusion and exclusion criteria that we are going to apply are achievement of stage 1 meaningful use, practice type, which I mentioned earlier, and then also restrictions on provider type, for example, excluding or pulling out all OBGYNs or internal medicine providers with subspecialties. And so our next steps. So we have 1 year left in our PHSSR grant and have a number of next steps ahead. First, we plan to stratify results by practice type and meaningful use attestation. We plan to create suggested inclusion and exclusion criteria based on the results, and we hope to create rules that other researchers can use and apply to their EHR surveillance systems. We're also working on generating fact sheets that present the validity of macroscope indicator definitions across settings that can be used as a technical toolkit or reference for other researchers working on EHR surveillance. And we hope to disseminate the fact sheets by the summer, and I believe they will be posted or available on PHSSR's website later on. And then additionally, we hope to publish on this work in the near future. And all this work would not be possible without this wonderful team at the New York City Department of Health Division of Epidemiology and the Division of the Primary Care Information Project, as well as at the CUNY School of Public Health. And my last slide is just a bit of a plug for the Population Health Community of Practice, which we refer to as the PopCop, which was created after a meeting that the macroscope team facilitated in the fall of 2014. They facilitated a meeting to establish a community of practice working on EHR's data for public health. And since then, it's grown to a really great group that has monthly meetings that's facilitated by Academy Health, and they discuss areas of EHR research, best practices, emerging topics in EHR surveillance, and if you're interested in the topic in general, I would encourage you to follow this link or get in touch with Tina and I so we can point you in the direction, because it is a really great community discussion. That is the end of the slideshow.
How do you transfer it back?
Great, thanks. So we have two folks providing commentary in today's presentation. The first one is Sharon Gwynn. Dr. Gwynn is the Deputy Commissioner for the Division of Epidemiology at the New York City Department of Health and Mental Hygiene, where she oversees the division's efforts to gather, analyze, and disseminate information about New Yorkers' health. She previously was the Deputy Director of the Strategic Information Unit at ICAP at Columbia University, where she provided technical assistance and capacity building support for routine monitoring and evaluation, surveillance of electronic health information systems for international HIV programs. Dr. Gwynn, you ready to provide some commentary?
Yes, I'm here. Can you hear me?
Yes.
Okay, great. Thank you for that introduction. And thanks to today's presenters for presenting your interesting and important work. And thanks so much for inviting me to be a discussant for today's webinar. As mentioned, I oversee the Division of Epidemiology, and within my division, we conduct a number of surveys that are used by the agency to assess population health. So I thought it might be helpful to take the opportunity to reflect on the contribution of the work presented today from the context of the New York City Department of Health. Public health agencies, such as the New York City Health Department, rely on population health data that's collected from robust surveillance systems to inform our decisions to improve the health of different populations. And while the systems to track infectious disease have been in place for some time, surveillance systems to track chronic diseases or their risk factors are still developing. At the Health Department, we've made great strides in the last 10 to 15 years to build and strengthen several important surveillance tools that have been critical to our work. One important tool that's provided our agency key population health information has been the Community Health Survey, or the CHS, which we use here to refer to it. It's a large telephone survey of adult New Yorkers conducted annually since 2002. And it's been an invaluable source of information about a broad range of health measures and also has allowed us to generate citywide, neighborhood, and subpopulation prevalence estimates, which are especially useful in a city as large and diverse as New York City. To understand health conditions and behaviors that impact the city's youth, we collaborate with the city school system to conduct the Youth Risk Behavior Surveillance Survey, or the YRBS. And we do that every other year, and it's a survey among the high school students to assess a variety of risk behaviors. We're also working to strengthen surveillance around children's health, and plans are actually now in the works to develop and implement a routine child health survey in 2008. Recognizing that there are limitations in assessing health status and risk behaviors through self-reported surveys, we embarked in 2004 to conduct the nation's first community-level health and nutrition examination survey. And so we used household-based recruitment to interview, examine, and collect biological specimens for laboratory testings among adult New Yorkers. And as was mentioned earlier, we repeated this survey in 2013 and 14 in collaboration with the City University of New York to assess trends in health conditions that could be measured through objective examinations. In 2006, we began requiring electronic reporting of hemoglobin A1C by laboratories to what we call the A1C registry. And the initial rationale for this was that we wanted to fill a critical gap in healthcare systems until innovations such as medical records, electronic medical records, were more widely adopted, and try to provide message to providers to improve diabetes care. And this registry has since helped us to understand the trajectories in the diabetes epidemic and to improve quality of care for New Yorkers with diabetes. As electronic data systems became more widely used, we, the Health Department, started to use aggregate electronic reports from emergency departments to conduct timely surveillance for syndromes, such as influenza-like illness and gastrointestinal disease. This syndromic surveillance utilized innovative approaches and took advantage of the availability of electronic information to provide an early warning system for some disease outbreaks. However, its use to monitor chronic disease is more limited. And so while we've made great strides in developing innovative approaches using electronic information, we still traditionally have largely relied on surveys to monitor population health. But surveys, as we know, can be costly. The target response rates are becoming increasingly difficult to achieve, and getting information for small geographic areas can be challenging. So there's a recognized need to continue to support innovative approaches to bolster our population health surveillance, especially with a focus on chronic disease. And today's talk on how the rapidly growing use of electronic health records and the wealth of information that they contain has allowed for the exploration of ways they can be used for population health surveillance. The many benefits of electronic health records include the timely availability of data, the cost efficiency of data collection, and the access to detailed clinical and laboratory information, as well as the large sample sizes they provide. So through this work shown here, we've developed evidence for the validity of some indicators, but we also have now a better understanding of the challenges involved in estimating some other indicators from electronic health records. We've also identified potential alternative approaches that we hope that researchers will find useful. For us, there's some important next steps. We plan to continue to refine how we analyze and use data. For example, electronic health record data contain a very large number of records, and so the standard errors of these estimates that we're producing are very small, which really limits our ability to compare estimates. We're working to estimate standard errors that reflect some of the uncertainties that are involved in collection of data around the electronic data, including the primary care, how the primary care doctor uses the electronic health record, or differences in electronic health record platforms. Having individual level information from the chart review has also proven to be especially helpful. We want to maximize the use of this information, and we plan to use the sensitivity and specificity data from the chart review to try to recalibrate some of the population estimates. And finally, we have more work to do to understand how the electronic health record data can be used to monitor trends. So this summer, we plan to look at trends from 2012 to 2015 and compare those to data that are collected through our community health survey. Aside from the validity work that's being done on the electronic health record-based estimates, the health department is already trying to rely on these data to provide timely insight into a whole host of questions. For example, we were able to assess trends of HIV testing before and after policy changes in New York City and the Bronx regarding HIV testing. And we also used it to confirm a smoking rate decline that we saw from the community health survey that I mentioned before. In summary, we're still learning about the electronic health record data and how it can be used for population health surveillance. Some key challenges remain, including ensuring data quality, understanding the generalizability of findings, and approaches to evaluate trends over time. Nonetheless, we're excited about the potential uses of electronic health records for surveillance purposes and plan to continue to use it to explore ways that electronic health record data can be added to the collection of surveillance tools used by the health department. Thank you.
Thank you so much. Our second commenter today is Mark Gurevich. Dr. Gurevich is the Muriel G. and George W. Singer Professor and founding chair of the Department of Population Health at the NYU School of Medicine. He's also the co-director of the Community Engagement and Population Health Research Core of the Clinical and Translational Science Institute, which is meant to bridge NYU and the NYC Health and Hospitals Corporation, and also leads NYU's participation in the New York City Clinical Data Research Network, which is funded by PCORI. So Dr. Gurevich, would like to provide some commentary?
Great, terrific. Thank you. Can you hear me?
Yes.
Great. So really just first to add my thanks to my colleague, previous presenters, and to the PHSSR initiative for this really great session and for the opportunity to participate. I really think this is groundbreaking work. And let me tell you why I think it's so important. In the worlds of public health and of healthcare delivery on the health system side, there are really these two sets of language about population health. When healthcare delivery systems think about population health and talk about it, they typically refer to the patients that are in their care. And when public health systems and thinkers and leaders talk about public health, population health, they're really thinking about the whole population in an area. And these two circles, the sort of clinical population health and total population health, are under there are increasing conversations really around the country about how to bring them closer together. Even though the language that we use to describe them is often a little bit overlapping. And we see these efforts in the form of accountable care organizations where healthcare systems are being asked to begin to think about taking responsibility for populations of patients, although it's often the clinical patients. But then in broader efforts like accountable care communities and accountable health communities, where there really is an effort to bridge healthcare delivery and area health. We see it in some large-scale experiments in Medicaid here in New York. The DSRIP evaluation is the DSRIP initiative is one to bring together all providers in a geographic area to be thinking about the total population health in that area. And we see it in the community benefit provision of the Affordable Care Act, where healthcare delivery systems are responsible for conducting community health needs assessments and then acting upon them. We see it as we begin to look at many proliferating efforts to use community health workers to bridge healthcare delivery with community health. So more and more, we are in a time where we're looking at strategies that bridge notions of area health with one of the influences on the people, the health of people in an area, which is the healthcare system. It's just one of many influences, I'm the first to point out, but it's a not trivial one. And so here in the macroscope effort, I think is like a cardinal example of harnessing electronic health records, something a product, if you will, of the clinical system to get a better, sharper lens, or to see how sharp a lens can one get using that infrastructure to get a bead on the health in a geographic area. And I think that is, and that this is a really big step in that direction. So, as has been pointed out until now, how can municipalities and other defined areas really go about getting the prevalence of important health conditions in their communities? That's really relied on interview-based national surveys, but it's often difficult to parse those down to a local level because, New York City is a big city, but many cities just don't have the population size to make those estimates stable. Also, surveys of that sort that rely on face-to-face interviews, obviously, as has been pointed out already, are quite costly. So if you think of a physician or really a clinician visit, that's also a survey, a direct interview interaction. It's not as nearly as standardized as something like Haynes or the New York City Haynes, but it represents in some cases an ascertainment and some measurement of people and their health. And so the question is, can that information in the aggregate be harnessed to create a snapshot of area health? And, the obvious concern is that people who are interacting with the healthcare delivery system who is in the electronic health records that PCIP has been working with to develop these estimates, that people in contact with the healthcare system do not exactly mirror all people in an area. But I think what we are finding is that for some conditions, the mirror is actually pretty high quality, and that's a big deal. So we've heard today that for a couple of very important chronic diseases that are responsible for a huge burden of suffering, of cost, and of healthcare utilization, the correspondence between the macroscope estimate and the meticulously obtained NHANES, New York City Haynes data is really very strong. And so I think the implications there are profound. So with electronic health record adoption nationally, in the area of 80%, the opportunities to scale this and to adapt it locally, this kind of approach, are multiple, and that's fueled by the fact that more and more regional aggregations of electronic health record data are are extant. So, here not every city has reproduced the Primary Care Information Project, the PCIP, with the query process that was described earlier by Tina McVeigh. But I think there are analogous processes that can now be developed against regional health information exchanges and HIEs, and even research-based collections of data like some of the ones that PCORI funds. So I think the conclusion is that it's really a very powerful proof of concept for being able to harness clinical data to get a bead and an accurate one on a subset of key chronic health conditions in an area. It's very exciting, and it'll be really interesting to observe as other locales begin to consider how they might adopt and scale analogous efforts. So thank you.
Great, thank you, Mark. Very insightful. Tina or Liz, do you have any response to those comments? Any thoughts?
I think the comments were terrific and really put a lot of context around the work we're doing, and I thank both discussants for such thoughtful comments. I see that there's at least one question. Should we start?
Yeah, I thought we'd probably move on to questions.
Okay, so there's a question from Gabriel Kaplan that says, is the strength of the macroscope indicator's performance due to selection bias, or does participating in the macroscope lead to better inputting of EHR data? I think the reason we really wanted to do this particular generalizability study is that PCIP really provides very robust quality assurance work with the providers, and the EHR has prevention-oriented bells and whistles that promote good documentation. So we really knew going in that the macroscope was built off of an EHR system that is quite unique and probably would show better results than might be available in EHR surveillance systems based off of RIOs that don't have the same kind of single umbrella quality work being done. And so that was why we really wanted to analyze these records, collect and analyze the records from the non-macroscope providers to really understand how our work can inform other communities. And so that's what we're really focusing on.
Also, just as a small addition to that, so the macroscope records all use one EHR vendor type, one vendor. So the chart review study included pretty much the bulk of the big vendors out there. So it was across a number of different EHR systems to use as a comparison that might more reflect what it might look like in other jurisdictions.
Great. So one question, and you all refer to this kind of in your next steps section of the chart review part of your presentation. So, your next steps are to stratify results by practice type and meaningful use within each practice type. Do you have any thoughts as to maybe which practice types might be better suited or might perform better in the chart, kind of with regards to the macroscope versus the other chart types? Does that make sense?
Yes, so early in my presentation I presented that inverted triangle that showed the data coming in from the hub and then it getting filtered by providers and then getting filtered by meaningful use or documentation quality. And that is the approach that we decided this week. One of the approaches that we would look at is that the data Liz presented today is really that top layer of that inverted triangle. It's all of the records that could have been pulled in from the hub that met general primary care criteria. And then starting really tomorrow, we're going to peel off the OBGYNs and the internal medicine specialists like endocrinologists and see if and how that improves their sensitivity and specificity. And then we'll peel off the practices that did not achieve meaningful use, stage 1 in 2013, and see how much more that improves the sensitivity and specificity. So that's really the approach that we're taking. We have looked a little bit by types of providers, hospitals, non-hospitals, using this unfiltered data set, and there's no consistent interpretation that you can take on those results. So that's why we're going back and saying, wait a minute, let's start and do the same filtering that we did for the macroscope with these non-macroscope records.
We have I see that we have another question in the text box, which is the EHR system being used for automated reporting of reportable conditions? And no, these aren't reportable conditions. They're chronic conditions. So it's not automated at all. We have to send queries to the EHR systems, send back and return data, and so it's a very...
For the data system that we're using, it's not, I do not believe that it's the mechanism that's used for reportable conditions, but the eClinicalWorks EHR, I expect has a different mechanism for automated reporting for notifiable conditions. But that's a different data stream.
Great, thank you. So I have one other question. So Dr. Gorbich had kind of alluded to the fact that New York City is a very special place, right? You've got a lot of folks, a lot of technology, a lot of kind of capacity there. If there were other communities that were thinking about implementing perhaps a similar program on a smaller size, what might you advise them to do? Like, how might they go about doing that? What would they want to prioritize for you?
I think one of the key things for any system like this is governance. And so before you start launching into the technology,
What did it actually take to get it off the ground?
I believe that we obtained funding for the macroscope development, for the development of the planning document, and for New York City Haynes, which was a huge piece of this project. Sometime in perhaps the spring of 2012. So it took us about a year to get the planning document out, and then a year to write all the queries, and then a year to analyze the results, basically.
Great, thank you. Looks like we are out of questions, so thank you for your time today.
Well, thank you. This has been terrific.
Great. So as you can see, we've got our webinars archived at the web address at the top of your screen. We have some upcoming webinars in February and March. So thanks again for participating in today's webinar. If you have need any information, have any questions, please feel free to contact Ann Kelly at the web address or physical address on your screen. Thank you.